Good morning, everyone. I am Noelle Smith. I'm the Senior Director of PA and Industry Research Analysis with the American Academy of Physician Associates. I will be welcoming our speakers for session one. The purpose of our session today is to frame the health workforce shortage crisis and discuss its implications for access to healthcare, worker well-being, and safe, high-quality care delivery. Joining me today, we have two wonderful speakers. First, we're going to have Hayden Kepley. Dr. Kepley has been the Deputy Director of the National Center for Health Workforce Analysis at the Health Resources and Services Administration for the past 4 years. Prior to this position, he served several years as the Special Assistant to the Director and was the first branch chief for performance metrics and evaluation in the National Center for Health Workforce Analysis, where he led the measurement and evaluation of over 40 healthcare workforce training programs in the Bureau's portfolio. Dr. Kepley came there from the University of North Carolina, Wilmington, where he directed the graduate clinical training program in psychology. He holds a PhD in both psychology and statistics from the University of North Carolina at Greensboro. And he completed a postdoctoral fellowship at the Johns Hopkins University School of Medicine, where he later served as assistant professor in the Department of Psychiatry and Behavioral Services or Sciences. We'll also be hearing today from Dr. Karen Lassiter. She's an associate professor of nursing and the Jesse M. Scott Term Chair in Nursing and Health Policy at the University of Pennsylvania School of Nursing in the Center for Health Outcomes and Policy Research, and the Senior Fellow of the Leonard Davis Institute of Health Economics. Dr. Lassiter's research, funded by the National Institute of Nursing Research and the Agency for Healthcare Research and Quality, evaluates the impact of nursing on patient outcomes with a focus on determining the value of nursing care in order to inform practice and organizational decision-making and policy. And with that, we will first hear from Dr. Hayden Kepley, who will be joining us today from Zoom.
Thank you, Noelle. I'm Hayden Kepley, and Noelle said I'm the Deputy Director of the National Center for Health Workforce Analysis at HRSA. And we can go to the next slide. And the next one. What I'm going to do today is talk about our new healthcare workforce projections that have been posted on the HRSA, the Health Resources and Services Administration website for both physicians and for a number of our behavioral health occupations. We're going to talk about where we are with our nursing profession projections, which are not published yet. And I'm going to talk about where you can find all of our information as well. We go to the next slide. If you haven't heard of us before, our division is in the Health Resources and Services Administration, and what we do is support public and private sector decision-making around healthcare workforce. And we do that by producing and disseminating a number of research findings and comprehensive data on the U.S. healthcare workforce is for both healthcare occupations as well as health support occupations. We can go to the next slide. Thanks. So our projections dashboard, which is on the HRSA data warehouse or data.hrsa.gov, has over 100 occupations where we make projections available or forecasting for over 100 different healthcare occupations. We just updated this at the end of October. So right now our projections run roughly 15 years into the future. So we're projecting to the year 2036 for these occupations. When we updated it most recently from our data last year, there have been a number of significant changes because a lot of the data that we use is now fully showing the impact of the pandemic. I think most of you probably know that a lot of major national level data sources run on a 2 to 3 year lag. So the information we get from the Census Bureau, the Bureau of Labor Statistics, and even from a number of professional organizations, has a 2 to 3 year gap between it when it's collected and when it's disseminated. And because we use all of that data to power our projection model, again, there's a little bit of a lag there. So our baseline year this go round is 2021 for our projections, and it's reflecting a lot of what happened in the pandemic. Most importantly, what we noticed is that there are significant amounts of attrition in a lot of our healthcare occupations that became very pronounced by 2021. So a lot of people were deciding to leave their healthcare professions entirely. A lot of people decided to retire, and we had more deaths than we previously had, in part due to the pandemic. So lots of attrition across all of the healthcare occupations. The other big thing that's changed is we have a lot more recent data on the extent to which behavioral health and maternal health care services are being provided by primary care physicians and workforce. And so that's also made a difference. So we have definitely improved data on behavioral health utilization, as well as the impact on integrated behavioral health settings. So there are definitely some differences in our workforce projections now than in years past. You can go to the next slide. So I'm going to talk about physicians first. We model 4 primary care physician specialties. All of them are showing significant shortages for the year 2036. There's an overall shortage when we look across all 4 of over 68,000 full-time equivalents in 2036. That's important to note that all of our numbers in our projections dashboard are full-time equivalents. They're not necessarily people. When we look across all 4, again, there's a percent adequacy of 81%. What that means is that given the supply of these 4 physician specialties, that there's only enough to meet 81% of the demand for healthcare services, again, in the year 2036. This is not right now. So this is looking forward. Beyond that, and I'm going to show you a few ways to look at this, there are significant distributional issues present as well. So while we have national numbers for a lot of these occupations and state level numbers as well, particularly for physicians, there are distributional differences and issues across all of the healthcare occupations. So even while there may be a percent adequacy that's about, or an occupation that's fully adequate to meet demand, there's may still be communities or states that don't have enough providers, and some counties that have no providers. So that's a big issue present in all the occupations. And I'm going to show that in just a minute, as well as metro and non-metro differences that we have here. These are the 4 physician specialties. So again, all 4 are showing shortages for the year 2036. These are significant shortages, particularly for family medicine, internal medicine, geriatrics. Even pediatrics is not going to fully meet demand. Pediatrics are a little different because we factor in population changes in the US. The only thing helping the pediatricians here is that people are not having children, and the birth rate has gone down significantly. That's the only reason here that pediatrics has less of a shortage than the other specialties here. We can go to the next slide. These are some of the metro and non-metro differences I was talking about. So what you can begin to see here are some of the distributional aspects or challenges that we see across our healthcare occupations. When you look in non-metro areas, these are counties in the US that are not in metropolitan statistical areas. That's what that means for the year 2036. So while the shortages look here on the surface as if they're smaller. What you also have to remember is that there are fewer people living in these areas. But when you look at the percent adequacy, there are also hardly any physicians to meet that demand. So the percent adequacy is very, very small here in these non-metro areas. So you can begin to see what's going on. And again, this is at a national level. So again, many communities without physicians at all. We can go to the next slide. What our dashboard also is able to show you is across the US, and this is at a state level, the percent adequacy. In this case, it's for internal medicine physicians. So again, you can see stark distributional differences even in this one healthcare specialty. And what we take away from this in our center, there are some states, particularly in the South and the West, that just have very significant shortages of physicians in their states to meet the demand level for healthcare services. Again, from, in this case, this specific healthcare specialty. That's also, again, very significant. And we can go to the next slide. We see the same pattern in behavioral health occupations as well. We forecast for 11 behavioral health professions, 9 of them are showing shortages. The other 2 are about adequate. So again, stark shortages here generally across the board for behavioral health. When we look at all 11, the percent adequacy is only 78%. So again, not nearly enough of the providers, again, at a national level to meet demand. We can go to the next slide. These are just 4 of the occupations that we are forecasting for, and you can see psychiatrists are still in very short supply. They're in short supply now, of course, as well. Similarly, addiction counselors and psychologists also very, very short supply at the national level. And again, and we can go to the next slide. What you can see here, this is like another state level look at psychologists. So even while we've got a national level figure that's showing a significant shortages, some states here are in even worse shape than that. So again, the same kind of pattern we see for a number of physicians, generally the South and the West, a number of states that are just have a grossly short supply of behavioral health, in this case, psychologists. We can go to the next slide. Our nursing projections, we're still waiting to calculate those. We're waiting on the latest results from our national sample survey of registered nurses, which is the largest and most comprehensive survey of nurses in the country, and we use that data to power our projections. We hope to have those actually in February, we hope. And so that's when to expect those. We are thinking that we will see nursing shortages at the national level as well, just like we have with the other healthcare occupations, but we don't exactly know for sure yet. And this is where you can find all of our information. Again, it's data.hrsa.gov. There's a webinar that shows you how to use our dashboard. There's complete technical documentation if you're interested in our healthcare workforce simulation model, which powers our projections, which you can also find on the website. I believe that's it. Thank you.
Thank you, Dr. Kepley. And next up, we have Dr. Lassiter, who will be speaking to us about the nursing shortage crisis.
Thank you for the opportunity to frame the nursing shortage crisis. Whoops, we're a little bit ahead of ourselves. That's okay. To frame the shortage crisis and discuss the implications for access to safe, high-quality healthcare. So I want to begin by discussing historic trends in the numbers of U.S. registered nurses to demonstrate that the nation actually has not only a robust supply of licensed registered nurses, but a rapidly growing supply. This is current data from the National Council of State Boards of Nursing, who's responsible for understanding who all the licensed nurses are in this country. And that data tells us that we have 4.7 million actively licensed RNs. In the 2 decades between 1990 and 2010, the supply of RNs grew by approximately 1 million. And from 2010 to 2020, we saw a doubling in that rate of growth, with an additional 1 million RNs added to the workforce in that single decade. And then data from 2020 to the present day demonstrates an increasingly steep trend in the national supply of licensed RNs. So from this evidence, I would suggest that the outlook for the current and future supply of registered nurses is strong, and that the causes of what we call the nursing shortage may likely be related to factors other than supply. We have also seen strong growth relative to historic trends in the numbers of newly licensed registered nurses. So current data for 2023 only include information for the first 3 quarters, but our annualized projections suggest that this year we can expect to see about 200,000 new registered nurses in practice. So what's evident from this figure is that we have steady growth of newly licensed registered nurses during recent years, including the years of the pandemic and during the recovery period. So the nursing shortage needs to be correctly diagnosed in order for the interventions to effectively mitigate the problem. While we see from the data that the US has a robust and growing supply of registered nurses, it doesn't discount the very real shortage that's felt at the point of care. And in fact, nurses on the front lines are telling us that they're working in untenable and unsafe conditions with unsafe workloads. We know that this leads to burnout, job dissatisfaction, and turnover. And the overall effect is this vicious cycle where we have high rates of organizational turnover, difficulties with recruitment, retention, clinician recruitment and retention. And all of this further exacerbates the problematic working conditions of clinicians who remain at the bedside, and it negatively impacts patient care and outcomes. So policies to produce more nurses, whether they're aimed at expanding the capacity of nursing schools or international recruitment of nurses, will not effectively solve the crisis if the root cause is not a narrow pipeline, but rather a leaky bucket. So how do we address the issue of a leaky bucket? This is data from over 40,000 direct care staff nurses working in about 357 hospitals, both before and during the pandemic. 48% of registered nurses reported high burnout prior to the pandemic. It increased to 51% during the pandemic. About a third of hospital nurses report being dissatisfied with their job, and nearly a quarter say they have an intention to leave their employer within the year. Most nurses characterize their hospitals as not having enough staff, and that's a problem that worsened during the pandemic, but importantly, it was already a problem before the pandemic. In preliminary analyses that aren't yet published, we asked licensed nurses who were not currently employed in a nursing job in 2021, why weren't they employed? And the leading reasons were burnout, insufficient staffing, and poor work-life balance. In recent work published in JAMA Health Forum, we also surveyed nurses and physicians in 60 hospitals across the country. And we asked them, what is the most important intervention your hospital could do to improve your well-being and reduce and prevent burnout? And 87% of nurses and 45% of physicians said improve nurse staffing levels. Importantly, we also found that physicians and nurses were more likely to report high burnout, job dissatisfaction, and intent to leave their employer in hospitals where nurses said there was insufficient staffing. Other top-rated interventions reflected aspects of workload and work-life balance that are really in the purview of management and leadership to address. What were the lowest rated interventions? Well, both nurses and physicians, they agree on a lot of things. They agree that resiliency training and the appointment of a clinician wellness champion were not likely to move the needle on their burnout. And going back to Dr. Christensen's remarks, she calls it communication. I would call it responsive leadership, listening to what your frontline clinicians need and responding to it. So if we really want to move the needle, I think prioritizing the interventions that clinicians say are most important is going to be one encouraging an evidence-based strategy to retain clinicians at the bedside and in the profession. In addition to strategically addressing burnout and turnover, what are some evidence-based strategies to ameliorate unsafe working conditions and reduce the shortage of nursing care at the point of delivery? So here I show an example of the impact of California's hospital nurse staffing policy that effectively increased hours of nursing care compared to non-policy states. So California is the only state with a policy requiring hospitals staff enough nurses to safely care for patients, though Oregon will be implementing a similar policy in the summer of 24. So what this study shows is that during the post-mandate period, patients in California hospitals were getting increasingly more hours of RN nursing care per patient day than patients in non-policy states. And following the Great Recession, we saw that the RN hours per patient day declined and were slow to recover in non-policy states, while in California, the hours of nursing care continued to climb. The overall effect of the staffing policy is greater numbers of registered nurses at the point of care delivery. In 2016, patients hospitalized in California were getting on average 3 more hours of nursing care per day compared to patients in other states. So this is an example of a state policy that's been demonstrated to sustainably increase the numbers of nurses at the point of care. There's been other research to show that in the post-implementation period, nurses in California hospitals had lower odds of burnout compared to those in non-policy states. But California is unique in a lot of ways, and you might be wondering whether such a policy is even tenable in states more rural than California. So here's data from the Bureau of Labor Statistics on the number of employed registered nurses per 1,000 population arrayed by U.S. state. So the national average is 9.22 registered nurses per 1,000 population. And as you can see, California has considerably fewer RNs per capita compared to other states at 8.2. In contrast, Missouri has well above the national average at 11.25 RNs per 1,000 and Kansas at 9.86. So this suggests that achieving adequate numbers of nurses at the point of care may be feasible despite geographic variations in supply. So in summary, the nursing shortage is not a supply problem, but rather a problem of having too few nurses at the point of care delivery. I've shown you that the US has a robust and growing supply of RNs, with more newly licensed RNs entering the profession than at any time in history. Therefore, the focus points for intervening to address the nursing shortage should be to stop the leaky bucket, target the root causes of clinician burnout, and employ evidence-based strategies to increase the number of nurses delivering healthcare. So thank you for your attention, and I look forward to the conversation.